for joining us at this Clean Slate Clinic webinar on the really important and frequently discussed topic of sleep in alcohol dependency and withdrawal, and indeed the post-withdrawal phase. In a minute, we'll introduce Dr. Jenny Lee, who will be joining me and being the main presenter tonight. Jenny is one of our fantastic GPs from South Australia. She's been with us for quite some time now, and has spoken on this topic in-house before, and it's been an excellent talk. And I will be helping Jenny with monitoring the Q&A function. So if you do have a question, please pop it in the Q&A tab at the bottom. You can use a chat room as well. I'll monitor both, and we'll try and answer them in real time. Maybe have a chat about those. So without taking up any of your precious time, I'll start by acknowledging the traditional custodians of the lands and waters from which we all meet, and I'd like to pay my respects to elders past, present, and indeed any Aboriginal and Torres Strait Islander peoples who are joining us on the webinar today. This always was and always will be Aboriginal land. Sovereignty was never ceded. All right, over to you, Jenny.
Thank you, Dr. Chris. Welcome, everyone, and thank you for joining us on Thursday night to talk about sleep, of all things, in alcohol dependency and withdrawal. This is the agenda for today. So we'll talk a little bit about sleep physiology and how alcohol affects it, the common sleep disturbances that we see and when they are consuming alcohol, as well as undergoing withdrawal and thereafter, and what that means in terms of recovery and relapse. And we'll discuss some strategies that we can suggest as GPs in managing sleep in alcohol recovery phase. So just going right back to the basics to provide a bit of context for the presentation, I'll go back to the boring sleep physiology with a picture of the little red bean there. That's the suprachiasmatic nucleus. So sleep is necessary for survival. It's a very active process. It has a role in rest and recuperation of the body and the mind. It also regulates our immune system. And the circadian rhythm is driven by the suprachiasmatic nucleus, which is like a conductor for the sleep-wake cycle. You mostly under by exerting the control with the release of melatonin, but also the suprachiasmatic nucleus is under the control of many other chemicals, including a few that's implicated in alcohol, and especially in chronic alcohol use. This fun graph shows the sleep-wake cycles. So to go from the wake to stage one, so there's the wake on the left, and then REM sleep, which is rapid eye movement sleep, and then stages 1, 2, and 3, which are non-REM sleeps, with a stage 3 being a slow wave sleep or deep sleep. So stages 1 and 2, that's the transition from the wakefulness to sleep. The heart rate and the rest rate drops, body temperature drops as well. And then as you can see from the image, the first half of the night, there's a bit more blue there than the second half of the night. So there's more time spent in non-REM sleep. And then the second half is when it's predominantly REM sleep. And sleep states are regulated, so deprivation of, let's say, REM sleep leads to pressure to enter REM sleep at subsequent sleeps, accompanied by the rebound increase in the REM duration once it begins, and similar with slow wave sleep deprivation as well.
With that cycle, Jenny, as well, sometimes people will say that at the end of each sleep cycle, which can last 90 minutes, depending on the person, that they actually wake up. So that where it dips into REM sleep. Some people can actually wake up at the end of each sleep cycle. So sometimes, so I'll often reassure my patients that when they say that, I wake up every hour and a half, doc, and as long as they're getting back to sleep within that 10-15 minutes, that could just be their normal sleep pattern.
Yeah, yeah. Yeah, I think as babies, anyone with newborn would know that their sleep cycles are 90 minutes and you hope that they consolidate over to the next cycle. And it's a learned process. It doesn't happen naturally. It'd be great if babies wake up sleeping overnight all the time, but they fortunately don't. We have to learn it. So yeah, when we see patients, because I'm a GP in Adelaide, so patients come in and say, I've got a sleep problem, doc. And I go, all right, go on to taking history, and they usually will say sleep used to be good, but it's not really good anymore, or it's always been a problem. I've always struggled with it. So as GPs, we cast the net wide, don't we? On the left are some sleep disorders taken from DSM-5. So, breathing related sleep disorder, that's just sleep apnea. And as we know, alcohol plays a big role in that because it dilates the upper airways and decreases the patency, increasing resistance, and they get more desaturations overnight, which has cardiovascular complications. On the right are some factors that can influence sleep. So substances, not just alcohol, but caffeine, nicotine, other medications. Illnesses can be allergic issues or upper respiratory issues, ENT. I'm thinking things like tonsils, sinus. Hormones doesn't have to be just thyroid, it can be perimenopausal, menopausal changes. Mental health, we know, is a big one in terms of its relationship to sleep. ADHD, autism as well has relationships to difficulties in sleep. Pain, chronic pain, fatigue, and life demands. What I mean by that is parenthood, work, travel can also lead to social jet lag as you need to accomplish, meet those demands. It eats into your sleep time. And then, of course, the stressors and the diet. And there's just so much influencing sleep, but recognizing the role of alcohol, the presence and the role of alcohol problem in people with sleep disturbances, I feel it's a safety issue because when we don't do the digging deep enough, and if we were to prescribe hypnotics or sedatives unknowingly and they've got alcohol in their system, then it can be a risk to the patient. So alcohol as a sleep aid, it's commonly used. A lot of our patients say that's how they started to drink alcohol regularly because it's convenient, it's cheap, it's viewed as low risk or acceptable hypnotic that induces sedation. Males are slightly more than females to use alcohol as a sleep aid. But alcohol really perpetuates sleep disturbance in the long term because it adds to the adding the tolerance and the increased consumption over time. It just becomes a problem that snowballs, and some patients feel quite frustrated because it feels unstoppable. And some other ways that alcohol might intervene with interrupt sleep could be increasing periodic leg movements that can fragment the sleep as well. It can provoke parasomnias like sleepwalking, induce gastritis or polyuria, which can lead to frequent awakenings. And if you have an elderly patient, then it's a risk for unsteadiness and falls.
Looks like that baby's going to have a coffee and a beer before bed. So look to
Great.
for that kid.
Balance it out. Yeah, so yay, fun, quick bike and break to lighten things up. So I just put this here again to provide further context in terms of neurotransmitters that play a role in alcohol dependence, because it becomes easier to understand and remember how alcohol affects sleep. So we know that alcohol enhances the effects of GABA, mediated chlorophyll flow into the cells. So that leads to neuronal hyperpolarization, and that inhibits the firing of the neurons, which produces the sedation, anxiolytic effects. And then in turn, in response to this, you get the postsynaptic neuron downregulation of GABA receptors. And that plays a role in tolerance and dependence, because a downregulation diminishes the inhibitory effect. And then you need more alcohol to achieve the same effect of the sedation. The glutamate on the right, alcohol inhibits the NMDA receptors, so it lowers the excitatory effects. And in turn, you get the upregulation of NMDA receptors, as well as reduction in glutamate reuptake in the body's effort to increase the glutamate neurotransmission. I really like this diagram. I use it a lot using my arm when I'm talking to patients to explain. It's perhaps a bit simplified, but it works quite well. So the equilibrium is at baseline. You've got the GABA inhibitory side, glutamate excitatory side. And then if you add the alcohol, you're stacking up on the inhibitory, making that tip. So the body tries to compensate by putting the glutamate on the excitatory side. If you take the alcohol away, you've taken the foot off the brake now. So it tips over to the glutamate, and you've got this hyperexcitatory, so you're accelerating even excitatory phase there. So that can explain some withdrawal symptoms like the palpitations, tremors, hypertension, anxiety. But what we do at Clean Slate during the detox week is we give them benzodiazepine, usually diazepam, to manage the withdrawal effects in attempt to balance it out so it doesn't tip wildly over to the excitatory side, and we wean it off safely over the week. Now, I divided up the effect of alcohol and sleep into short-term and long-term. Short-term meaning when people use it and have an effect as a sleep aid, I guess. Especially at high dose alcohol, it tends to decrease the initiation of sleep. So help with the initiation of sleep, so decreases sleep latency. It initially inhibits REM sleep and increases the slow wave, the deep sleep. But in the second half of the night, you can get the sleep fragmentation that Dr. Chris talked about by getting rebound REM. And this is, I think of it like a short-term withdrawal effect once the body has metabolized alcohol. Even like 2-3 hours after the alcohol level reaches zero, you still get the increased stress hormones and sympathetic activities up there, and the sleep disruption in the second half of the night as a result. The happy hour late afternoon drinking. So I see this on boards at pubs and things like that, walking past. But we know that up to 6 hours before bedtime, alcohol intake can disrupt sleep, even when alcohol is no longer in the brain at bedtime. And yeah, risk with the next day impairment, of course, the reduction in the alertness and reaction time performance. And that persists for several hours, even after blood alcohol level goes to zero. And now on to long-term. So this is the chronic use dependent patients. The hypnotic effects decrease with chronic use because of the tolerance. So they need to drink more. And because hypnotic effects decrease, your initiation to sleep is not good, so you increase sleep latency. There's reduction in both slow wave sleep and REM sleep, and there's change in the sleep regulation. So the alcohol itself interferes with the phase control in the suprachiasmatic nucleus, because all the neurons in the SCN respond to a GABA, and you've got excessive GABA activity there. And GABA also modulates the light effect of light onto suprachiasmatic nucleus. So the phase delay and the phase advancing in the sleep-wake cycle is disrupted. And you get reduction in melatonin levels, which reduces melatonin. This is because it reduces melatonin production and efficacy and delays the melatonin peak rise. And you get the increase in the stress hormones, as we talked about.
And certainly, melatonin is, well, I mean, we'll talk about this in a bit, but melatonin is a common medication that you can use in that post-withdrawal phase. And certainly that's how I describe it to my patients, is that your brain's been using alcohol to switch itself off for so long, your brain's forgotten how to do it itself in some ways. And melatonin being the sleep hormone, if we give your brain a bit of a boost in those early days post-withdrawal, it can just help remind your brain how to switch itself off, is sort of how I describe it to the patients. And anecdotally, at least, it works well for that phase. But our drinkers will often say, I've tried melatonin, it doesn't work. And and it won't work whilst they're drinking. Well, it's unlikely to. It'll be hard to tell if it did anyway. But again, as you said before, you don't want to sort of give melatonin to someone with an undiagnosed sleep disorder or sleep apnea. So you have to be pretty certain that the reason that they're not sleeping post detox is that alcohol withdrawal, post alcohol withdrawal syndrome, and not something else underlying.
Yeah. And we work closely in partnership with the GPs as well. So when a patient finishes up the withdrawal week, we write a discharge letter to GP. And if sleep is an issue preceding the chronic alcohol use, and how they've gone with the sleep throughout the withdrawal week, we assess it at post-withdrawal assessment and write in the letter what's happened, what the patient might want to work on, what they might come to see you for, just to help to collaborate. So what happens to sleep during alcohol withdrawal? So when a patient is in alcohol withdrawal, that week, I'm talking about when they've stopped the alcohol in the first week, the sleep latency is still longer. They get reduced deep sleep, slow wave sleep. Sleep efficiency, which I'll explain a little bit later with equation. It's poor, which means they are just spending more time in bed without actually sleeping. So it's tossing and turning. They initially get reduced REM. So in the first 1 or 2 days, the latency to enter REM sleep gets shortened. But then once they enter REM, they don't spend much time in it. So they cycle a bit fast out of that. And then the subsequent day, so day 3 and beyond, you get the REM rebound because you've been deprived of the REM, so the body tries to catch up. But it can return to normal with protracted abstinence. And as Dr. Chris said, in the withdrawal phase, because they're deficient in melatonin, they've got this excessive wakefulness hormones, neuroadaptation has to happen. That takes time. Some studies say it can take 5 to 9 months to relearn that sleep initiation. And some studies suggest that it can be up to 12 months before sleep is restored to baseline. So this is maybe like a patient journey. So if they start off with sleep disturbance because of physical health, mental health, lifestyle factors or environmental factors, and then if they were self-medicating with alcohol, they might see some short-term benefit, but then develop tolerance. That little cross there is to signify withdrawal from alcohol, so they stop drinking, but now they're dealing with this changed brain. And some research in this area suggests that insomnia following alcohol withdrawal is not a straightforward insomnia, because the body and the mind have been changed by chronic alcohol use, and the sleep homeostasis has been disrupted. But in saying all of this, not everyone has awful sleep though. Some patients I see at post withdrawal week say, I've had the best sleep I've had in many years, and that continues on. So it's not all bad news.
it's often one of the early
Mm.
major benefits that people notice, isn't it? Sort of during and after detox, it's like that waking up feeling refreshed for the first time is just so rewarding. And yeah, I really get people to reflect on that as one of the big differences that stopping drinking or having a break or even reducing can really make.
Yeah, yeah. And like when they wake up, rather than feeling hungover, irritable, foggy, they wake up and they feel like, oh, wow, this is how great I could have felt. So it's really good, really
Yeah,
good.
my father-in-law used to say there's a difference, son, between passing out and coming to and going to sleep and waking up.
Yeah.
He was speaking from experience.
Now a patient has, yes, stopped drinking alcohol, but sleep challenges can continue in the few. So they can still have increased sleep latency. So taking a while to get to sleep, and then they get less total sleep and reduce sleep efficiency, as I talked about earlier. Fragmented sleep can continue because you get the REM rebound continuing. Sleep stage changes can become more frequent. So spending more time in that light stage 1 sleep, where they're more fidgety, twitchy, more movement, more awakenings, and less in the deeper slow wave sleep stages. Now, when they're spending more time in that REM sleep, as I said, it's because they're cycling through quickly, but the quality of the REM sleep is poor as well. They have more eye movements in that REM sleep as per REM episode. And one research thought that indicates poor quality. Just wanted to draw your attention to something called post-acute withdrawal syndrome. This is not something I knew about before I started to work at Clean Slate Clinic. But this is the persistent subacute symptoms that can start a week after stopping alcohol. So this is not acute, but they can last for weeks to months. And the symptoms are up there, but that you can read, but it can signify the ongoing stress hormone sympathetic drive. Can be really impairing for the patients, and it can be associated with risk for relapse in attempt to settle these symptoms down. And these symptoms are not gradual or continuous, so it's not like they're very severe when you stop drinking, or a week after you stop drinking and then gradually get better. Sometimes patients will have good few weeks or months and then it'll just suddenly rear its ugly head. And it reflects a period of neuroadaptation in the prefrontal cortex and nucleus accumbens, the reward systems in the brain, and the neurotransmitters, the receptors that have been upregulated, downregulated. It doesn't happen in a uniform way. That's why it can be unpredictable and fluctuating in symptoms. It can improve over time and within the few months up to several years of sustained abstinence. There's no medications that you can use to treat these. Really, it's a lot about education, validation, self-care, relaxation, exercise, psychological support. And in this phase, alcohol or removal of alcohol can unmask some mental health, I guess I don't want to say disorders, but mental situations as well. So whether it's diagnoses that have been missed, such as ADHD, and that comes up quite often. Yeah.
Yeah, it's poorly defined, isn't it? And patients will talk about pause, which this is. It's certainly talked about a lot in This Naked Mind with Annie Grace talks about pause, and so yeah, it's poorly defined. I mean, there's good evidence to suggest that it does take around that 100-day mark for the neuroadaptation to recover, for those GABA receptors to be upregulated again, and all of the things you've talked about, and as you say, there's this unmasking, isn't it, the reasons that people have been drinking for all these years, the social anxiety, the ADHD, the PTSD, then they're unmasked and those symptoms can come to the fore as well. So it's really about that longitudinal therapeutic relationship that certainly as GPs we're in a great place to be able to foster, and certainly why we follow people up fairly intensively for those first few weeks and months at Clean Slate, and you know it's a 12-month follow-up indeed that we have. But it's also certainly, you know, doing this work as a GP for so long, it's the most rewarding thing that I'd ever done, is to see people recover, people get through this phase, for their joy to come back to their lives. And you know, as their dopamine receptors are settling down and all of a sudden they're finding the joy in the small things that they'd just forgotten about, you know, they're, you know, reinvigorating their love of painting or the things they used to love when they were younger or before drinking got in the way. And yeah, so yeah, it's the best part of it, I think.
Now, looking at what does sleep disturbance mean in terms of alcohol relapse? So these are findings from different studies. So sleep disturbance and increased latency to enter sleep show that patients are more likely to relapse by just 4 weeks after stopping alcohol. And those who relapsed reported more sleep problems than those who didn't. And difficulty falling asleep differentiated relapsers from abstainers in one study. And one study found that after controlling for alcohol dependence and depression severity, baseline insomnia was the only significant predictor of relapse. So sleep problems should be addressed early in recovery with everyone, and initiating treatment if problems persist beyond 1 month. So that's, we advise patients to go see your GP, speak to them about your symptoms and your concerns. You may need some investigations or even referral to a sleep physician. And some alcohol dependent patients are told to just focus on not drinking, focus on abstinence, and sleep will just get better. But they really need help in this phase, in this period. So they need to be monitoring their sleep and seeking treatment. Okay, so I'll talk about some strategies. First, non-pharmacological strategies. I won't go into all of them in detail, but I'll just highlight what they are. So CBTI, I standing for insomnia. It's just CBT techniques to address the sleep anxiety, to lower that. Sleep psychologists can do CBTI, but anyone can do CBTI. There are lots of books, self-help books, online resources on it. Really good insomnia modules at This Way Up as well. We'll share that at the end of the presentation. Sleep restriction, I'll talk a bit more about that in a little bit, but that's basically increasing sleep pressure and consolidating the sleep. Stimulus control is to reduce the conditioned response by associating bed with wakefulness at the subconscious level and realigning the bed as a place for sleep and not for thinking and worrying, because a lot of the people, that's the first time of the day where they've got some quiet to themselves. So it's important to start the wind down bedtime routine, so that you're not decompressing and reviewing the day in the bed or planning tomorrow in your bed. Relaxation. There's good data for progressive muscle relaxation exercise if it is practiced to be done regularly in addressing sleep disturbance and alcohol withdrawal, following up alcohol withdrawal. Sleep hygiene, we all know about. And others, what I mean by that is addressing the environment and just educating the patient about sleep and considering things like light therapy, sleep restricted eating, like intermittent fasting, can have a role in sleep management. So yeah, we all know this, sleep hygiene, daytime and evening. focusing on strategies during the daytime and evening. So setting up the ideal bedroom environment, and then the daily exercise regimen by going outside in the morning to get the sunlight into your eyes, to stimulate, and then walking stimulates metabolism, avoiding the usual culprits, including a nap in the afternoon so they don't get the catch up, because that will just take away from building the sleep pressure, as well as consistent bedtimes and stress management. So yeah, sleep restriction, I find this really interesting, and it works really well for patients. It's called a rubber band technique, and you'll see why. And the aim is to improve sleep efficiency, so to restrict the time spent not sleeping in bed. So when you're in bed, you're going to sleep. So when do you try this? When patients are tossing and turning for 2-3 hours in bed, trying to initiate sleep, when they get disrupted, fragmented sleep, waking frequently overnight, and then needing to catch up with naps throughout the day. And then, if they are struggling with stimulus control strategy. So first step, get them to complete a sleep diary. It can look something like this. So they just monitor, try to estimate the hours of sleep that they had, how long it took for them to fall asleep, the environment, the preceding events that happened, and then how they felt when they woke up. And then they calculate a percentage. And how they do that is this sleep efficiency number. How you come up with it is you take the total time asleep and then divide that by total time awake and multiply that by 100. And then you continue on with this method if it's poor sleep efficiency. And you ask the patient to decide on a sleep window. So when do you want to wake up? So if they want to wake up at 6 a.m. and if they've calculated that over the last week, the total time actually I slept in bed was 5 hours, then you just go back 5 hours from 6 a.m. and tell them you go to bed at 1 a.m. They're not allowed to go to bed earlier, no napping during the day. Sounds a bit harsh because they're already sleep deprived and you're going to sleep deprive them further. But this is how you build the sleep pressure. And then get them to record it for 1 more week and then review again, and then get them to calculate the percentage. And if their sleep efficiency decreases, then they're still tossing and turning. So you need to be a bit more strict. So you're going to take away 15 minutes or 30 minutes either way. So either changing the window from 1 to 6 a.m. to 1 a.m. to 5:45 or 1:15 to 6. And if it's 80 to 85%, then you continue on with the same sleep window. And then if they see an improvement in sleep efficiency, so they're spending more time in bed actually sleeping, then you can increase the sleep window by 15 to 30 minutes. So changing from 1 a.m. to 6 a.m. to 12:30 a.m. to 6 a.m. or 1 a.m. to 6:30 a.m. And then this is why it's a rubber band, and you continue until desired outcome. This takes time, takes a bit of homework from your patient. It's not hard. So once you explain it to them, they can go home and stick with it. But it can take a few weeks, but it can be really, really helpful to reset their sleep.
I think using the CBTI techniques are important if you're going to use sleep restriction, because it really works. But often an initial reaction is, are you crazy? I'm not sleeping and you're telling me to go to bed later. How can that possibly make sense? But a lot of that CBTI, as you said, is people get, when you're lying in bed, and certainly this has happened to me, and you're not sleeping and you've got to get up for work the next day, and you put yourself under so much pressure to fall asleep that you then can't, and to have those relaxation techniques to allow yourself to be in bed with your eyes closed and not be stressed out and concerned is a big part of it, I think. So generally I'd start with a bit of CBTI and then move to sleep restriction when someone's a bit more comfortable with the fact that, not sleeping for 10 hours a night isn't going to, be completely detrimental in the longer term to them, if that makes sense. A bit of reassurance.
Yeah, exactly. And that sleep anxiety, and if you ask them, think about the worst night's sleep that you've ever had, or maybe you didn't even sleep at all, and what happened the next day? Like, was it a disaster? And they'd often say, no, it probably wasn't. I was probably very tired, but it wasn't that bad. And just reducing the hyperarousal response to sleep and not getting enough sleep, and addressing it gently definitely does help to engage. Pharmacology. I put this up here because these are some common medications that patients are prescribed to help with sleep. So there's no great data for long-term use for any of them, I'd have to say. And certainly, you can see I crossed out the benzos and Z drugs. They are contraindicated in patients who have been treated with for alcohol dependence. So do not use them. We do not recommend using them. And yeah, I mean the only one that I might consider is melatonin in the acute phase after withdrawal, because they're deficient in melatonin. So yeah, I might prescribe it and say take it for a week or two and then go see your GP if the sleep problems persist.
Such an important point, isn't it, that benzodiazepines are contraindicated in anybody who has current alcohol use disorder or even a past history of alcohol use or substance use disorder, because they're inherently addictive drugs. If you've suffered with a use disorder, you are at higher risk of then developing a benzo dependence. It's also really dangerous for people to be using benzos if they're drinking because of the risk of overdose, respiratory depression. And we do see that. We see that people who are drinking will have poor sleep, as we've discussed. They'll go to their GP with poor sleep as their presenting complaint, be given prescriptions of Z drugs or benzos, and can develop poly dependence then on benzos and alcohol. And because benzos are so good at mimicking alcohol, and that's why we use them in withdrawal, again, it's lighting up the same pathways in the brain as alcohol benzos are. So not just your risk of addiction to benzos is higher, but if you're in recovery, so you're no longer drinking, and you pick up some benzos from wherever you can pick them up, it's lighting up those same pathways in the brain. So not only are people at risk of the benzo dependence, they're also then at risk of relapsing back to drinking alcohol. So unless you're going to be doing a withdrawal, an alcohol withdrawal, I would never prescribe benzos or Z drugs to anybody with either a past or a current history of alcohol use disorder. Yeah, really important point, I think.
Yeah. Now, just to touch on craving reduction medications and how they affect sleep. So one meta-analysis I looked at studied 26 studies, overall found lack of robust evidence for any of the craving reduction medications, in addition to the ones listed here, for their effect on sleep post-alcohol withdrawal. But these two are on PBS, and I just wanted to bring them up here for discussion. So naltrexone, it can either cause increased insomnia and or somnolence, either way. Acamprosate have a few studies that show some benefits for sleep. So it can improve the sleep continuity and improve the sleep architecture. So if you look at remember the phases of sleep, it can increase the slow wave sleep and how quickly you go into the REM sleep. And because acamprosate is it reduces glutamatergic neurotransmission, the excitatory system, which is dysregulated in alcohol use disorder. That's probably how it works. So yeah, these are some online resources. This Way Up has a free insomnia module. It's quite good. It's self-paced. Patients can use it. Smiling Mind app, I think you need to pay for. Headspace as well. Process C and Process S. It's just talking about 2 circadian and sleep processes. I use it sometimes in educating patients about sleep. There's a free CBTI website that it's very text heavy, but it lists everything, all the strategies for CBTI. Sleep Health Foundation is much prettier than that and has lots of good library of resources too, as well as our website, Clean Slate Clinic. This is just a screenshot from it. Under resources, if you go to GP resources, you'll find information there. So on the left, that's what it looks like once you click on the GP resources page. You can look at the independent evaluation of our program done by Sydney University. And yeah, the resources for GP takes you to, on the right are some snippets that I took from there. So the other webinar available, or other webinars available for you to access. Yeah. And those are the references. Thank you.
Amazing. Thank you so much, Jenny. That was fascinating. Such a fascinating topic that so many of our patients have many questions about, because it's just so important to our everyday functioning and so heavily affected by alcohol, as you really nicely pointed out. Thanks to everybody for joining us. Does anybody have any questions that they have for Jenny or myself? I couldn't see any in the Q&A box. Feel free to write some questions in there. If you do have any questions, then you can email us at any time, services@cleanslateclinic.com. As Jenny said, there is that free resource page, which I'm quite proud of. It has free resources for people with alcohol use disorder, for our patients and clients, for support people, and for loved ones, and also for GPs and healthcare professionals dealing with this issue. Okay, lovely. Well, yes, thanks very much. I'll end the recording there and yeah, say good night. Oh, hold on. Not a question, just a thank you. Thanks, Vanessa. Thanks for joining us. All right, you're saved by the bell. Get an early mark and have your dinner.